It's 5:05, so I am officially going to get started. And as other people kind of join in, then that'll be a great addition. And like I said, any questions that you have, just make sure that you put them in the QA, and then I will answer them when I'm done with the talk. So I'm going to share my screen so you can see. I like to, have some pictures and things like that to talk about in our talk. So I'm going to share my screen now. Hopefully you can see everything and you can still see me. So thank you so much for joining tonight's seminar. For those who don't know me and haven't seen me on these webinars or on social media before, I'm Jenna Friedenthal. I am a reproductive endocrinologist and infertility specialist, board certified in both OBGYN and reproductive endocrinology and infertility. As a reproductive endocrinology and infertility specialist, I specialize in the diagnosis and management of reproductive disorders, mainly infertility and fertility preservation, such as in egg or embryo freezing. Just for a little background about me, I completed my undergraduate education at Yale University. I then completed my medical degree at the Albert Einstein College of Medicine with distinction in research. I then completed my residency training in obstetrics and gynecology at New York University. And finally, I completed my subspecialty training in reproductive endocrinology and infertility right here at RMA of New York through the Icahn School of Medicine at Mount Sinai. And this is where I was invited to stay on as faculty. And that is how I am here today. And so I am really excited to talk to you about all things fertility and fertility preservation. So if it's okay with everyone, I'm going to get started on our slides. I think a good place to start is to talk about what it takes to make a baby, what your first visit with an REI like me is like, the diagnostic testing that we do, and then walking you through the process of fertility preservation. Okay. So in general, what does it take to make a baby, right? So there's the 4 basic ingredients. Number 1, you need to have a uterus that is functionally normal, that can house and sustain a pregnancy. Number 2, you need fallopian tubes that are open and without any disease. And that's where fertilization actually happens, is in the fallopian tubes. Number 3, you need to have sperm of sufficient quantity and quality to fertilize an egg. And number 4, you need ovaries that are ovulating in a regular, predictable way, a healthy, genetically normal egg. And so in terms of breaking down what's going on at the level of the uterus and the ovaries and talking about fertility preservation, let's just start with the first visit. So what to expect at the first visit? Well, whether you're a patient that's trying to conceive or you're somebody that's interested in egg freezing, it should overall be a very similar experience, because at that first consult, I go through your complete history, your family history, any medical problems, surgeries in the past, any medications that you are taking, allergies, anything that might affect your reproductive health, your ability to conceive, or our ability to perform an egg freezing cycle, if that's what you're looking to do. And then we perform an exam, and that exam involves an ultrasound and an exam of the blood via hormone testing. So let's break that down a little bit more. So with the ultrasound, the first thing that we look at is the uterus. We always want to make sure that we know if there's anything structurally concerning that, would need to be addressed either before an egg freezing cycle, or of course, if you're someone trying to conceive, before you continue trying to get pregnant. And with regards to egg freezing, while we are not involving the uterus itself, sometimes women can have what are called fibroids, which are just benign growths of the muscle of the uterine wall growing on the outside of the uterus in such a position that it can actually obscure or limit our ability to see or access that ovary during an egg retrieval. And so it's really important to not just look at the ovaries, but the uterus too, to make sure that there's any challenges there that we know about them up front and can address them up front. So we look at the uterus first, then we look at the ovaries. And so in addition to looking for any, abnormal cysts or structures that could affect reproduction, what we actually do is a count of the number of follicles we see in each ovary. We call that the antral follicle count. And that gives us a sense right away of your ovarian age. Am I seeing the number of follicles that I expect to see for somebody your age? Am I seeing more, or am I seeing less? And I should say that I always use the phrase follicle and egg interchangeably, but eggs are microscopic. We can't see eggs when we look on ultrasound, but we can see follicles, which are simply the fluid bubbles that surround a growing egg. And so we can use a follicle as a surrogate marker for eggs on ultrasound. So this is the ultrasound. Then we look at blood work, looking at all of the hormones that may impact your reproduction, including things like your thyroid hormone, your prolactin levels, FSH, LH, and importantly, arguably the most important hormone is something called the AMH, which stands for anti-Mullerian hormone. So AMH is a hormone that is made by those small follicles. Therefore, the more eggs that you have left, the higher your AMH will be. And on the other hand, the fewer eggs that you have remaining, the lower your AMH will be. Now, I think this is a subtle, but it's a very important point. Aging affects those of us with ovaries in two ways. Number one, it decreases egg quantity over time. And number two, it decreases egg quality. By egg quality, I'm talking about the chromosome content of those eggs. And will they, when they form with a sperm, merge with a sperm, will they lead to an embryo that has the right number of chromosomes to be consistent with life or not? And so all of the testing I've talked about so far, the ultrasound, the blood work, these are quantitative tests about the number of eggs remaining, which is helpful information because it gives us a sense as to where you are in your reproductive lifespan from a quantitative perspective. But none of this testing is evaluating egg quality. And I want to say this really clearly and loud for the people in the back. There really is no test for egg quality. The best test, of course, is when someone decides they want to get pregnant, how easily or difficult it is for them to conceive, assuming that they have sort of normal otherwise testing. And I just think it's important to mention because I commonly see patients who come in for a consult because an AMH level was drawn for whatever reason, and maybe it's lower than expected for their age, and they're worried, does that mean I am infertile? The answer is no, that is not what this means. And we know that because we have followed women that were ovulating regularly who are trying to get pregnant, and we've looked at their AMH levels to see if there was any relationship. And time again, we find that there is no relationship. And that makes sense logically, right? Because AMH is not the marker of egg quality. It does not reflect that type of information. So whether your AMH is 2, 1, 0.1, when the time comes that you're trying to get pregnant, as long as you are still ovulating regularly, you have no reason to assume that your ability to get pregnant with that egg is any worse off than anybody else who happens to be also trying in your age group with a higher age. Hopefully that makes sense. But if it doesn't, if there's any concerns or questions, you just put that in the Q&A and we will come back to it, I promise. Now, I know this is mostly focusing on egg freezing, but I just wanted to kind of complete the fertility testing, so to speak, that people often go through. We've talked about the uterus. We've talked about the ovaries. We've talked about the questions we ask at the first visit. If you are trying to conceive, we do recommend 2 other tests. The first is a semen analysis to determine whether there is any male factor infertility at play. And the second is called an HSG, which stands for hysterosalpingogram. It is a test to make sure that the fallopian tubes are open and healthy and without any disease. So ultimately now let's focus on the actual egg freezing process because that's really why we're here, right? So why freeze your eggs? I think that is one of the most important questions to answer tonight. So, listen, not to bring it back to Forrest Gump, and hopefully I'm not so old that people on this call don't know that movie, but right, eggs are like a box of chocolates, right? In the sense that over time, there are fewer and fewer chocolates or fewer and fewer eggs. So as I said before, aging affects egg quantity, but also those that are remaining decline in their quality. So though they go bad. So ovaries are like a box of chocolates. And I think it's really important to remind everybody of the reality of female reproductive aging. So the maximum number of eggs that we will ever have is actually before we're even born. We have the maximum number of eggs when we're approximately 20 weeks old inside the uterus still, before we are even born. And by the time we're born, we've lost 80% of those eggs. We're born with about 1 to 2 million eggs total. By the time we hit puberty, this number has dropped significantly to only about 350,000 eggs, give or take. and we will only ever ovulate about 400 to 500 eggs. So therefore, by the time a woman reaches 30, she has already lost over 87% of her eggs and 97% of her eggs by the time she ages and turns 40. And nothing, not pregnancy, not birth control use, nothing aside from fertility preservation can stop the process of losing the eggs in this way. The only thing that can stop that and protect your fertility is something like egg freezing. And again, not only does quantity decline with age, but unfortunately, so does quality. So over time, even if pregnancy occurs, we have higher chances of miscarriage, particularly as we approach our late 30s to early 40s. The age of 35 is relevant, not because a normal pregnancy is impossible at that point, but more so as you can see, the slope of this line here starts to change. So this is a figure looking at the percent of miscarriages based on how old the woman is at the time of conception. And so you can see at around age 35, there's a pretty impressive inflection point with a significant increase in the risk of miscarriages. And that's a direct reflection of egg quality. I think another way of looking at this is this figure here. So this is a figure taken from a study looking at over 15,000 couples that underwent IVF to get pregnant. The reason they're a good population to study is because with IVF, we routinely recommend doing something called PGT, pre-implantation genetic testing, wherein we take a biopsy of 3 to 5 cells of what would become the placenta. We send that off for chromosome testing so that person knows of the embryos they have which ones are chromosomally normal or not. And so on the x-axis here is female age. On the y-axis is the percent of embryos in each of these age groups that are chromosomally abnormal. We call that aneuploid, will not lead to a healthy live birth. And I would ignore this uptick here. When this has been repeated, it's pretty much flat and then goes up in this way. And so again, on the one hand, it's not like you hit age 35 and, this immediately jumps to 100% abnormal. But on the other hand, I think you can see the slope of this curve starts to really change and more aggressively move towards 100% abnormal, beginning actually at around 32, 33. So at 32, we expect about 25% of your eggs on average to be abnormal, which is a lot, but that's normal reproduction. We're just not that efficient when it comes to egg quality. It means that, for a 32-year-old, on the other hand, 75% of their eggs should be healthy and normal. But things change quickly. So by 34, about 30% of their eggs are abnormal on average. By 35, it's about 35%. By 37, it is about 45% of your eggs are bound to be abnormal. By 38, it's about 50%. So 38 is the age where now it's there are more eggs that are abnormal than normal on average. At 39, it's about 55 to 60% of someone's eggs are abnormal. And by age 40, it's about 60 to 65% and so on. And so this is, I think the data that shows us how that ratio of, healthy to unhealthy eggs changes and sort of flips on its head in the wrong direction as you make your way through your late 20s, early 30s, late 30s, and 40 and beyond. And this is all, the data that shows us the role of aging on ultimately female fertility. So I think the takeaway from all of this is that we are born with a finite number of eggs. The number of eggs that we actually have available for ovulation and pregnancy is quite low and continues to drop as we age. And in addition, the quality also drops significantly as we age. And there is nothing that we can do to prevent this aging and protect our fertility except for fertility preservation via either egg or embryo freezing. Hopefully this makes sense. But any questions, please feel free to post them in the QA, like I say. So now that we've talked about why to freeze your eggs, I think it's important to understand how both egg freezing and fertility testing works. And to do that, I think it's important to start with a quick overview of actually the menstrual cycle, because it's through our understanding of the menstrual cycle that we know how to interpret fertility tests and also how to take advantage of the menstrual cycle for egg freezing. So at the beginning of your menstrual cycle, your ovaries release a certain number of follicles into the visible area of the ovary. Again, I use the phrase follicle and egg interchangeably. And so these are all ovaries on ultrasound. And these are actually my ovaries. Yes, I have done ovarian stimulation. I needed IVF, not just for egg freezing, but But for embryo creation, for a variety of reasons, happy to talk about that either offline or in an appointment with me. But the stimulation process is exactly the same. So I can speak to what it's like to go through ovarian stimulation. So as you can see, these dark circles here are follicles. And so your ovaries at the beginning of a period release a certain number of follicles at the beginning of every month. And from there, you're bringing some signals to your ovaries via hormones to pick one of those follicles to be what we call the dominant follicle of that month, the winner, so to speak. All of the other follicles that were released just die off on their own. And that one follicle ovulates its egg, and if sperm is present and the stars align, right, that egg fertilizes and makes its way to your uterus, and you become pregnant. And if not, that egg also dies off, and the whole cycle resets 2 weeks later. So that's the menstrual cycle. Now, why is this important to know for egg freezing? So back to how egg freezing works. With egg freezing, all we are doing is actually just giving you more of the hormones that your brain is already making, so that instead of those other small follicles dying off on their own while the one big follicle gets chosen, instead, we're trying to grow all of those healthy follicles into nice, big, healthy, mature eggs that instead of ovulating, we retrieve at the time of the egg retrieval and then we freeze. Okay. So hopefully that makes sense. Now that we've kind of gone through why to freeze your eggs, a little bit about the initial visit and how egg freezing works in general, I thought it would maybe be helpful to just review what it's like to do egg freezing on like a day-to-day basis so that you get a sense of what to expect if you were to do an egg freezing cycle here with me at RMA. So I think it's nice to kind of be able to see this as a visual of, on a day by day basis, roughly what to expect. I always say that this is a basic recipe, but recipes are always individualized, right? And so part of how we decide when to bring you back, what dosing for your medications, et cetera, is based on your individual ovarian reserve testing and your response to the medications. But generally speaking, the way that it works is that we sync it up to start again, essentially with the beginning of your period. So you call us on day one of your period. We usually bring you in then a couple of days later, like day 3 of your cycle, to do just another quick check-in with an ultrasound and blood work, make sure everything looks good to start. And if so, that's when you start the medications. And so what that involves is usually 2 medications a day. They're not the scary in the butt intramuscular injections. They're insulin needles. If you've ever seen them, those are really, really tiny. They go into the abdomen or the thigh. We then bring you back in, usually 2 to 3 days later, to do another check-in, see how you're responding to the medications with, via ultrasound and blood work. And that's when I can decide then whether or not we need to change your dosing of medications up or down. In the beginning of the cycle, you're coming back to see me every 2 to 3 days. And then as you can see, by day 10 or so, that's when I tend to bring you back every day, just to make sure that we are timing everything as perfectly and optimally as possible. And we are open every single day because eggs wait for nobody. And we want to choose to do this on the day that is best for you and your chances for success. For most of my patients, by day 11 of your cycle, you're actually ready for what we call the trigger medications. And then the retrieval happens 36 hours later. So you would take your trigger medications the evening of, in this example, day 11, and then your retrieval happens actually on day 13. And like I say, there can be some variability in cycle length, kind of depending on how quickly or not, you respond to medications, but this is kind of the general overview. And now for the actual egg retrieval procedure, this is actually what it looks like. I think this is like a relatively good cartoon kind of schematic. So what you're looking at, this is the vagina here. This is the cervix going into the uterus, fallopian tubes, and then the ovaries. So the ovaries actually sit right next to the vagina and the vaginal wall in real life in most women. And so essentially the actual egg retrieval procedure. So first of all, it's done under anesthesia. So you are asleep. It is not general anesthesia. So, no tube down the throat to breathe or anything. It's all just done through the IV, but you are definitely asleep before we start. And the actual procedure itself is basically the same as a transvaginal ultrasound, except that on retrieval day, you are asleep, number one. And number two, on retrieval day, at the end of the ultrasound probe, there's a very small needle that you can see here attached to the end of the probe that we use to make small puncture here on the right and then on the left. If we're thinking anatomically, I know it looks like left and right for your screen. That is how we access your ovaries. That's how we aspirate the fluid in these follicles. And that's how we retrieve the eggs. So everything is done vaginally, nothing is done abdominally. There's no incisions or cuts or anything like this. And we say risk of complications, meaning bleeding, infection, injury to the bowel, bladder, etc., less than 1 in 1,000. It's really quite rare. Most people, in terms of just thinking of symptoms, most people shouldn't have many symptoms throughout the cycle, to be honest with you. I would say feeling tired, occasional headaches, occasional breast tenderness. That's the most common stuff. And then right around retrieval day is when some people can start to feel some bloating, some cramping, pelvic pressure. That can last for a couple of days after the procedure too. Most of my patients go back to work the next day, but you also see how you feel. If you needed an extra couple of days to relax, that's also normal. And that is pretty much it for the actual egg retrieval. I think, this is the last figure that I wanted to touch on, and then my slides will be done and I'll be here to answer questions. But I think the most common question that I get at the end of all this is, do I have enough eggs and how many eggs is good enough, right? And to some degree, that's going to be in the eye of the beholder. But I think I'm a data-driven person, so I think, as much objective data as we can have would be great. So this is the best data that's been published. And as you can see here, on the x-axis is essentially the number of mature eggs that were frozen. And then the y-axis is a probability of having at least one live birth broken down by the age at which you froze your eggs. So you can see it's really important. Age is the number one predictor of success, meaning that, let's say you're 35 or under, and let's say you have 10 eggs frozen. That gives you a roughly 70% probability of having at least one baby from this process. On the other hand, if you are 40 and you have 10 eggs frozen, that gives you only a 30% probability of having at least one live birth. So you can see age plays a major role in the odds of success, which makes sense, right? Based on everything that we talked about before about how aging affects egg quality and ultimately pregnancy rates. I say for patients that are 35 and under, if we can have at least 15 to 20 eggs frozen, I think that puts you in a really comfortable position because as you can see here, that puts you at about an 85 to 90% probability of having at least one baby from this process. But do I have patients who say, I want more than that because I know I want a really large family? Absolutely, right? And that's when we can think about whether or not we need to do more than one cycle. On the other hand, I have patients who we have a diagnosis of diminished ovarian reserve where we're thrilled if we get 5 eggs, right? Because we aren't sure if we're able to ever get any based on how low their ovarian reserve is. So I think it's also important to speak with your physician about your individual ovarian reserve testing so that you can kind of set expectations for yourself, either about how many eggs would be a good outcome or how many cycles you want to do to try to get to those optimal numbers. So this is where I'm going to stop sharing my screen. And I'm going to start looking at the Q&A and we can kind of start going from there. Okay. So first question, what is the latest age that you can do egg freezing on average with and without an embryo? So I think, first of all, just to clarify a couple things. So egg freezing is separate from embryo freezing. So egg freezing is where we retrieve the eggs and we freeze them unfertilized. Embryo freezing is where we've taken those eggs and we fertilize them, grow them into embryos, and then freeze them. We actually usually then biopsy them for PTT and then we freeze them. So, what's the latest age that you can do it? That's an individual center by center thing. I would say, so there's no technically hard and fast rule really beyond like the age of like 54. But I think as you can see, odds of success are going to be lower as you kind of make your way through your 40s and beyond. So I think that's an individualized conversation. For most of my patients, I would say, beyond the age of 45 is when we have like a real talk conversation about pros and cons of doing either egg or embryo freezing. But have we cycled 45-year-olds or people that are even older than 45? We definitely have. So that's a conversation to have with your doctor at your center. Someone said, sorry, I joined late. Is it possible that a recording of this presentation be provided? That's an excellent question. I don't know that this is being recorded, unfortunately, but I can kind of circle back, and if not, you can make an appointment with me, and I'll be happy to kind of go through all of this again in person, and we can kind of tailor the conversation to you. Okay, next question was, can you do this testing while on birth control, or do you need to stop first? I'm very early in considering this. The answer is yes, we can absolutely start with testing while you're on the birth control pills. The one caveat I tell my patients is that sometimes for people who have been on birth control pills for a long time, 5, 10, 20 years, Sometimes they can make the ovaries kind of look artificially suppressed, meaning that it will look like there are fewer follicles than there actually are in real life, and can sometimes make it look like your ovarian reserve is lower than it really is. If we saw that, then I would say I would tell you to go off the birth control pills for like a month or so and do retesting and see if we see a difference. But I'll tell you, for a lot of my patients who have been on birth controls for, pills for even 10, 20 years, I look at their ovaries and they look just as awake and healthy and active as ever. So it is absolutely testing that can be done while you are on birth control pills. Okay, the next question was, how does egg freezing impact egg quality? So by and large, it doesn't, right? I think the only thing to keep in mind is that there is what we call a thaw survival rate, meaning what proportion of the eggs survive the thaw when you want to use them. And I would say that's where sort of drop off can happen. Every center is different in terms of their egg thaw survival rate. At RMA, our egg thaw survival rate is about 80 to 90%, meaning of 10 eggs frozen, we expect at least 8 or 9 of them to survive the thaw, which is above national average. It's really good, but it's not 100%. But generally, once they have survived the thaw, the odds of then that leading to a healthy embryo that's chromosomally normal is exactly the same as if you did IVF, up front. Okay, next question. Do you specialize in IVF for women aged 45? Are you open to taking on clients? The answer is yes. I'm definitely open to taking on clients. I've definitely had patients that are 45 and older. I always think it's about setting expectations up front, right? And there are certain things that we just can't control once you're 45 years old. The main thing that we can't control is egg quality, plus or minus egg quantity too. But that doesn't mean that we can't do IVF and that we can't try IVF. We absolutely cycle patients. And we do sometimes have success and can get a euploid embryo, but I think there's always, the older that you are when you're doing IVF, the greater the chance there is that we may not have a usable embryo even after multiple cycles. But that doesn't mean that we can't try. And so, yes, that's certainly something that I do and that we do here. In terms of the costs, it's going to be a really individualized thing, right? Because thankfully, I'm here in New York State, and we have a lot of insurance plans that are now much better about providing coverage for fertility preservation. But it all depends on your plan and your benefits and your specific kind of coverage. So each team, including my own, I have a finance coordinator who is amazing. His name is James. He is like a godsend. Every time you meet with me, he talks to you too to let you know what your specific insurance plan provides in terms of coverage and things like that. So, is it true that the probability of a live birth is higher with a frozen embryo than with a frozen egg? The answer is no, and not really. But what is different between freezing eggs and freezing embryos is the thaw survival rate. So back to what I was talking about before, egg thaw survival rate at our center is 80 to 90%. The embryo thaw survival rate is much higher. It's about like 97%, give or take. And that's really because embryos are larger when we freeze them. They're about 60 to 100 cells. They just survive freezing and thawing better than an egg, which is literally like one cell, a single cell. So that's where there's a difference and drop off in terms of success. But again, once the egg or embryo survives, the odds of ultimately live birth are the same. Do we accept, or really, should we work with Maven? Yes, I have plenty of patients that are using Maven for their insurance. Are there concerns to consider if I'm overweight but otherwise healthy? Listen, what we say is that in general, for the purposes of egg freezing, not really. I would say the only thing is to just know what your BMI is, but because a lot of fertility centers have a BMI cutoff just for the anesthesia process, not actually the egg retrieval process, because there's data to show that if your BMI is above 40, you're at higher risk for aspiration, which can cause like pneumonia and sepsis and other bad things, than if your BMI is below 40. And so, like in most freestanding fertility centers, that's the only sort of thing that you need to keep in mind. Do we know that being overweight can impact pregnancy rates for when you want to use your egg or embryo down the line? Yes, we do have data to show that even with euploid embryos, there can be an association with lower success rates when you are overweight or obese. But that, in my opinion, can be a long-term project. I mean, I have a lot of patients who will freeze their eggs, and now, they're coming back because a few years later they've, lost the weight, and now they actually want to use their embryos. So for the egg freezing process, I would say it doesn't affect egg quality, which is the good news. Is there anything that could be done to improve AMH levels and follicle counts? Unfortunately not, right? And so that kind of harkens back to the beginning of the talk where your egg count is the same as it's ever going to be, like from birth, and it just continues to decrease over time. And there is nothing that we can do to change that, really. Despite whatever sort of, things that you read on the internet, supplements, they're unfortunately bogus supplements. And I think they're pandering towards a vulnerable population. And so there's nothing really that you can do to change your quantity. No. Can you do this process while on a GLP medication? It's a great question. So the answer is that you can essentially stay on the GLP-1 medications until you actually start the medications. That's when we actually stop them, patients, take them off of them for just while you're doing the retrieval cycle. Only because, again, there's been some literature to suggest slightly higher risk of, again, aspiration, which is where food from the stomach comes up and is inhaled into the lungs while on a GLP-1. And so out of an abundance of caution for anesthesia risk, we just want to make sure you're off of it just for the, essentially week and a half before you do the retrieval, and then you can start right back on it the next day. If you are doing embryo freezing, does your partner do their own initial consultation, or are you a pair together? Jennifer, a pair together. Yeah, it's sort of I'm a one-stop shop where we do all the, history, discussion, exam, ultrasound, and then blood tests together. And then usually we'll schedule the semen analysis on a separate day, just when it's convenient for the partner, et cetera. But you don't need to make a separate appointment for the male partner for embryo freezing. What kind of modifications and drug doses do you make for someone with breast cancer? It's a great question. The most important thing that we do for patients with breast cancer is use an additional medication called an aromatase inhibitor. Women with breast cancer are often very familiar with aromatase inhibitors because they're used a different brand of it, generally speaking, different version is used often in post-treatment kind of like long-term surveillance, because what it does is keeps someone's estrogen low. So particularly for women with breast cancer who have estrogen receptor positive breast cancer, meaning that the cancer is responsive to estrogen, they want to keep their estrogen level low for many years to come. So we use that medication too while you're undergoing ovarian stimulation so that your estrogen level is staying really low throughout the cycle, and therefore is not impacting tumor growth in any way, shape, or form. Since we're doing that, we have more flexibility than when it comes to dosing of the medications that we use to stimulate the ovaries, because we're reducing the only, thing that is really a concerning risk factor, so to speak. Okay. Is CoQ10 one of those bogus supplements? That is an excellent question. And I will say in general, I am a less is more type of person when it comes to supplements, because not only are most of them not evidence-based, but they're also not FDA regulated. It is like the Wild West of medications, because there's no one overseeing what is in them, if what they claim is in them is actually in them in the concentration that they claim, without additives like arsenic and mercury. So I am definitely less is more. I would say my exception to that rule is coenzyme Q10, because generally speaking, it is a pretty benign supplement, and there is some data to suggest that it may improve egg quality and quantity. So of all the supplements out there, that's the one that I'm like okay with patients taking. I would say there's not a lot of great data to show that it actually changes outcomes, but is one of those ones that I think is a low enough risk that I'm okay with patients using. What is the high level process after thawing the egg if you're trying to conceive at that point? So yeah, fast forwarding a few years, if you've frozen your eggs and you now are thinking about using the eggs, basically it's pretty straightforward. Either you're coming to me with a partner whose sperm you want to use, or donor sperm of choice. Either way, it's the same process. We thaw the eggs. We then individually fertilize each egg with the sperm of choice, grow them into embryos. We generally do PGT, so we biopsy the embryos and then we freeze them. And then we'll give you a call. We'll let you know how many eggs have made it to the biopsy stage, and then it usually takes a couple of weeks to get the biopsy results back. So you know now, of those eggs that you had, how many of them led to embryos that are chromosomally normal, so to speak. Can you be on birth control during this? You can be. So the answer is you can be on birth control right up until the point that you start the medications. But once you start the medications, you need to go off the birth control pills, because by definition, birth control pills are suppressing your ovaries from growing follicles. That's how they prevent pregnancy. So we don't want that to happen. We want the opposite. We want the follicles to grow. And so you need to be off the birth control pills just for that time that you're doing the retrieval. After the retrieval, you'll usually get your period a week or so later, a week or two later. Once you get your period, you can jump right back on the birth control pills again. Okay, and then last question, should we avoid using retinol skincare products for the face and prescription antifungal creams to prepare? Um, Generally speaking, I say that it's fine to continue with all of that stuff because it's different. Egg freezing is very different from embryo freezing, right? And most importantly, it's different from actively using those embryos to try to get pregnant. That's when we need to talk about things like stopping spironolactone, stopping, vitamin A, skincare products, things that we know can cause birth defects. But for egg freezing, it's a different scenario because you're not trying to get pregnant right away, presumably, and using those eggs. And so it's fine to actually continue all of that. Okay, great. One more question hopped on here. Love that. How does taking testosterone affect the egg freezing process? It's a great question. So I certainly have patients that are using testosterone for any number of reasons, most commonly for gender affirming care while they're doing egg freezing. There is some data to suggest that using testosterone actively while also trying to freeze your eggs may affect maturity of the eggs and therefore the quality of the eggs that we can freeze. So in an ideal world, we do sometimes recommend stopping testosterone, for maybe a month or two before you do the egg freezing, just to try to improve the chances of success while you are undergoing the ovarian stimulation. That being said, there are definitely patients who don't feel comfortable stopping the testosterone, and I think that's a conversation that you have with your doctor. And we can definitely continue to use the testosterone while you are undergoing the egg freezing process, knowing that it may affect the amount of healthy mature eggs that we ultimately get from that cycle. Oh, good. A few more. Is there anything that you recommend doing for optimal number of eggs per retrieval? And general egg quality and quantity. I'm assuming maybe you're meaning like lifestyle stuff, like things that you can do to optimize. Again, I'm kind of a less is more type of person. I think, coming in early is the number one thing that you can do, getting started sooner rather than later because age is the number one factor in determining your success. You'll read a lot on the internet about diets, lifestyle things. Certainly if you were a smoker, smoking, we know, can affect egg quality and egg quantity, both short term and long term. So, stopping smoking, both of cigarettes and marijuana, is the best thing that you can do. Beyond that, people ask me a lot about the Mediterranean diet. Look, it's a healthy lifestyle, right? So, I'm not going to tell you to not, cut out processed carbs and focus on unsaturated fat because that's good for your body. And anything that's good for your body is going to, potentially improve the health of your ovaries. But at the same time, it's a stressful process for some people. If you need a cupcake on a Friday night to get you through your day, that's not going to be the thing that affects your outcome. Okay. If you see 10 follicles on an ultrasound, what proportion are usually able to be retrieved? Oh, it's a tough question to answer without more information for that person, right? Because, 10 follicles at baseline, are all of those follicles going to respond to the medication? No, right? But what proportion of them will respond can vary widely. I've had patients with, 10 follicles where 8 out of 10 respond really well, 9 out of 10, and I've had patients where only 2 out of 10 grow well. And a large part of that is just dependent on which eggs are released that month and do they have more hormone receptors and therefore are more sensitive to the medications or fewer hormone receptors and are therefore less sensitive. So that there's just a lot of variability with that, can't kind of make a general statement. Um, will exposure to secondhand smoking affect egg quality and quantity? It's a great question. I don't know that there's any published data on that, but what I would say is, occasional exposure to secondhand smoke, like when you're taking the subway, is probably okay. If you're living with somebody who smokes, I would say that would be more of a concern because extrapolating it from other areas of medicine, right? We know that secondhand smoke can be associated with asthma in kids, right? We know that secondhand smoke can be associated with increased risk of pneumonia in people who live in the house and things like that. And so I think it's a fair extrapolation then to say that secondhand smoke could affect your ovaries too, even if you're not the smoker. I just don't know if there's any official published data on that. Okay. I think that is everybody. I think that's all of the questions. Really, really good questions. Okay, amazing. Well, thank you for sticking it out and for all your really thoughtful questions. I hope that this was helpful. If you want to see me for a visit, call RMA. Phone number is 212-756-5777, and ask to make an appointment with me. I'm Jenna Friedenthal. Again, it was really, really nice to be here and be able to kind of talk through this with you guys. I hope to see you soon.